welcome back to the channel. Continuing the lectures in neurological history, today we will discuss what are the important points you should take in the history of diplopia. Now, if your patient is coming to you with double vision, first of all, you have to take the onset. First point is onset, whether it is acute, subacute, or chronic. Acute onset diplopia, it can be seen in CVA, diabetes mellitus, trauma. Subacute, it can be seen in infections, inflammations, and chronic diplopia, it is seen in tumors, abscesses, multiple sclerosis. So, first important point you have to take, it is onset. In the second point, we have whether it is uniocular or binocular. That is, if the patient's diplopia clears out on closing one eye, it is binocular diplopia. Otherwise, it is uniocular diplopia. Third point is whether the diplopia it is present in the horizontal gaze or the vertical gaze. If the patient has diplopia in the horizontal gaze, then which cranial nerve is affected? Sixth. And if it is present in the vertical gaze, it can be third, it can be fourth. Now, coming to whether the diplopia it is present in the fourth point, it is whether the diplopia it is present in the far vision or the near vision. If the diplopia is present in the far vision, then it is a sixth nerve which is affected. And if it is present in the near vision, it is a third nerve which is affected. Now you have to ask for the fifth point, image splitting. Whether the images are splitted horizontally, that is side by side, or vertically, one above the other. Now if it is side by side, it is basically because of the sixth nerve. And if it is vertically, then it can be because of the fourth nerve. Now, what is the variation with the diurnal? That is, diurnal variation is present or not. It can be seen in basically neuromuscular junction disorders like myasthenia gravis. Now, seventh point, is there any postural variation? Sometimes the patients who have raised ICP, they have diplopia, and which is more on bending forward. Then eighth point is whether it is painful diplopia or not, that is patient has pain in the eye or not, because inflammatory causes, infectious causes mostly have pain associated with diplopia. Then ninth point is there any associated headache? If the headache is present, it can point towards raised ICT. Then in the 10th point, you have to see there is any abnormal posturing of the neck, that is any head tilt is present or not. Now if a patient is having right sixth, then he will see towards the right side to decrease the diplopia. And if it is present in the third, if the patient has right third nerve involvement, then he will look towards his head is tilted towards the left. Then coming to the 11th point, whether there is any associated ptosis or proptosis, to rule out whether there is any orbital apex or whether any disorders of the eye are involved in it or not. Okay. Then 12th point, you have to ask for the history of trauma, because sometimes the blowout fractures of the orbit, patient can have diplopia because of the traumatic sixth nerve or traumatic cranial nerve palsies. Then in the past history, you have to take important history, past or present history, that is whether the patient is diabetic, hypertensive, or any vascular disease is present or not. This is done to rule out the microvascular causes of diplopia. Then any drug history is important. In cases of acute diplopia, patients on phenytoin, zonisamide, they can have diplopia. Then you have to ask for the associated histories of dizziness, vertigo, ataxia, weakness, to rule out any brainstem involvement. So these are the 15 points you should ask in a patient who has history of double vision.